Yeah, hello all. My name is Arnav Srivastav. Thank you to the Kidney Cancer Association for inviting me to speak and present some of our research at the Rutgers Cancer Institute of New Jersey. This is our project titled Delaying Surgery for Clinical T1b to T2b Renal Cell Carcinoma, Oncologic Implications in the COVID-19 Era and Beyond. So sort of the inspiration for our study really started in the spring of 2020 when the novel coronavirus was sweeping through the United States and the rest of the world. And it led to fundamental changes across virtually every industry, but in particular healthcare, where we had to make different types of choices about how we treat our patients and where we disperse our resources, as we had a new kind of unprecedented variable that we had to deal with on a daily basis. In the world of urologic oncology, this manifested most prominently in the delay of surgeries. And many of these surgeries were non-emergent, but potentially curative cases. And part of the rationale for this was the preservation of ventilators for patients who might need the ICU from the coronavirus, the preservation of PPE to prevent the spread of the virus to patients who would come to the hospital and then maybe stay in the hospital after their procedure. And really on the East Coast of the United States, this lasted from about March to May or June, resulting in delays for most of our patients from 1 to 3 years. Now, when we start to think about the effects of delaying partial nephrectomy or radical nephrectomy for localized kidney cancer, studies started to come out to sort of quantify and give recommendations as to how we should approach these patients. This was one of the first papers that came out by Stenslin, which was published in the European Urology Journal, and they said that most CT1 masses can likely safely be delayed, but the data gets a little murkier for masses that were T1b or greater, and this was really due to a paucity of information at the time. A subsequent review done at our center by Dr. Brian Schinder tried to sort of quantify and collect some of the recommendations from previously published papers. And what we saw was fairly mixed recommendations, some saying do not delay the surgeries for larger tumors, some saying that delay was likely safe. And as a result of these mixed recommendations, different institutions had different policies on how they approached these patients with localized kidney cancer. Now, in a review of the information, we sort of arrived at this state at the time we started our project. So the majority of T1A masses were likely safe to delay for 1, 2, 3, 4 months. And a lot of this was steeped in the excellent prospective active surveillance literature that we have for small renal masses. On the other end of the spectrum, for T3A and beyond, we understand that these are typically tumors with aggressive biology, and especially if they've already invaded local vasculature. These are cases that likely should not be delayed because of the current progression of the cancer. But there still remains a large swath of patients between these two ends of the spectrum, T1b to T2b masses, larger masses which are confined to the kidney. And this is really where our paper exists and what we were trying to study. We wanted to answer this question. So we had two major study objectives. The first was to assess the risk of PT3A upstaging in patients with clinical T1b to T2b kidney cancer. And the second was to assess the risk of surgical delay on overall survival for these patients. So in terms of our methods, we got our data from the National Cancer Database, which is a large national oncology registry based in the United States. We really focused only on those patients who would receive surgery to really pare down to the population that we cared about, the population who did have their surgery delayed. And as a result, we excluded those patients who were on active surveillance, who got percutaneous ablation of their tumor, or who never went to surgery for whatever reason. When we were constructing our study population, we defined surgical delay as time from diagnosis to time to surgery, as these were often coded as different times. And we substratified our population as follows. So surgical delay would be defined as less than 1 month, 1 to 3 months, or greater than 3 months. And then within each clinical stage strata for CT1b, CT2a, and CT2b tumors, we performed a unique survival analysis and upstaging analysis. To assess the risk of PT3A upstaging, we performed logistic regression. We used Cox proportional hazards and Kaplan-Meier curves to assess overall survival. We also performed a sensitivity analysis to make sure that our findings would be robust when we change our cut points and when we assess variables as continuous rather than discrete groups. So moving on to our results, this is an excerpt from our table 1, essentially. We had roughly slightly over 29,000 patients with a median follow-up of a little more than 3 years. And as you can see, as the clinical stage of the tumor increases, the time from diagnosis to surgery decreases, as one might expect. So the first thing we did was we simply tabulated the risk of PT3A upstaging as it relates to surgical delay within each clinical stage strata. And here we don't see an obvious association between the two. Really, it's pretty homogeneous within each clinical stage strata, whether you got your surgery immediately or whether you got it after 3 months. We further studied this using multivariable logistic regression and really came to the same conclusion. So at this time, we felt pretty comfortable saying there was no clear association between surgical delay up to 3 months and PT3A upstaging. Sensitivity analysis also confirmed this. Next, we moved on to overall survival. And again, we did not see an association between surgical delay and worse overall survival among CT2A and CT2b tumors. However, we did see a slight association in CT1b tumors. Those patients who had surgery greater than 3 months after diagnosis seemed to have slightly worse outcomes than patients who went to surgery a little quicker. And this bore out again in our multivariable analysis. However, the closer we looked at this, we sort of came to the conclusion this was likely a more spurious finding. And we had a couple reasons to think so. So number one, we saw no association with PT3A upstaging and surgical delay among CT1b tumors. Number two, we saw no association with surgical delay and PT3A upstaging or overall survival among CT2 tumors. And this is likely a finding that is stooped in the impact of unmeasured confounders, patient comorbidities, and the difficulty that some patients may have in coordinating their care. So a patient with a large amount of medical comorbidities requires a longer time of medical optimization and care coordination before they can receive their partial radical nephrectomy. And those patients may experience worse overall survival, likely reflecting comorbidity status rather than true oncologic progression of their tumors. In terms of the limitations of our study, so the NCDB is a very powerful tool. However, it is still a retrospective administrative database, and we unfortunately do not have the data granularity that one might expect from a well-maintained institutional database. Additionally, as a limitation of the NCDB, we do not have cancer-specific survival nor recurrence-free survival. In lieu of this, we used PT3A upstaging and overall survival to help us get an idea of what these might be. Additionally, we did not have tumor growth rates. One might expect that a tumor that's growing very fast on serial imaging, we would take to the operating room a little quicker than a tumor that has a more indolent growth pattern. Lastly, we understand that our surgical delay cutoffs were based on our own institutional experience. There's a chance that if we change the cut points as to defining what is delayed surgery and what is immediate surgery, we may end up resulting in different associations with survival and surgical delay. However, we tried to mitigate this using a fairly robust sensitivity analysis, which confirmed our findings from the main analysis. So in conclusion, the COVID-19 pandemic has definitely resulted in the delay of elective, possibly curative procedures for patients with kidney cancer. We wanted to study what was the delay in these larger localized kidney masses, T1b to T2b kidney cancer. And what we find is that for the majority of these patients, surgical delay of up to 3 months and possibly beyond does not seem to compromise their survival. However, when we triage these patients, we have to be very careful to incorporate the patient characteristics, the tumor characteristics, and the overall stability of the healthcare system at the time. And those are really the keys to making sure that we optimize our patient care and help navigate the new challenges in healthcare with the coronavirus. Thank you.